published in 2019 and revealed on 625 patients shows combination of pathways. They did MRI pathway alone and they did TRUS biopsy, guided biopsy alone. The MRI pathway detected prostate cancer in 39% with a clinical significance of 25%, while the TRUS guided pathway revealed prostate cancer in 48% with a clinical significance of 23%. And insignificant cancer was detected more in TRUS guided biopsy pathway, and that the total core reduction was 89% if MRI pathway was used alone, while missing only 4% of clinically significant cancer. And so, more and more patients come to be investigated by multiparametric MR. And that's why it raises the question, is additional value of dynamic contrast to T2-weighted images and diffusion weighted was claimed to be minimal by the PIRADS version 2.1 2019. And abbreviated MRI, I mean by abbreviated MRI is biparametric MRI. I mean by this only diffusion-weighted images and T2-weighted images without contrast injection emerged as an alternative protocol. Why? Why do we do this? Why did you think of this? Because multiparametric using the 3 sequences is more time-consuming. It shows it needs intravenous contrast with the potential risk of nephrogenic systemic fibrosis and more costly. While biparametric MRI using only T2-weighted images and diffusion-weighted images without contrast injection is more rapid, safer with no contrast injection, and less costly. So, what about the accuracy of biparametric MRI without injection? There is no significant difference in negative predictive value and detection of significant cancer, as said by Droste et al. Cochrane 2020, but slightly lower sensitivity and the higher sensitivity is being detected. And with, according to Braz et al. 2020, biparametric MRI offers comparative sensitivity and specificity to multiparametric MRI in detecting clinically significant prostate cancer. So let's use the biparametric MRI, but still, the Baz et al. Said heterogeneity doesn't allow definite recommendation to be made. There is a need for prospective multicentric studies of biparametric in biopsy-naive men. So what about the PIRAD-3? The PIRAD-3 is the big issue in the PIRAD scoring system. PIRAD-3 in biparametric imaging without contrast injection is higher level 10 to 20%. And 50% will be upgraded, will lead to many more men that have to be undergo biopsy. And we need to use additional approach by PSA density and risk calculator. So what's the meaning of PIRAD-3? What I mean that I don't know actually. Let's revise again the PIRADs. The PIRAD-3 is the intermediate scoring system. The intermediate score equal that I cannot put the lesion in 1 or 2 with a very low, unlikely significant cancer, and I can put them in the 4 and 5 PIRAD scoring because it's likely to present. So what to do? Let's revise again the PIRAD system. And we know at the peripheral zone, we judge on the peripheral zone, and the primary sequence is the diffusion-weighted images. The primary sequence in the peripheral zone is the diffusion-weighted images. So PIRAD-3, when I see the diffusion images with a mild to moderate hypointense lesion, which is not corresponding to 1 or 2, or not corresponding to 4 or 5, where for PIRADS 5, I can see a very well-defined focal hypointense lesion, which is less than 1.5 centimeter, and the hypointense lesion in PIRADS 5 more than 1.5 centimeter. So here comes the role of dynamic contrast enhancement. If we inject the patient with PIRAD-3 contrast enhancement, contrast injection, if it does not enhance, it is still PIRAD-3. But if we injected the PIRAD-3 patients and it enhance, it gives us it upgrade to PIRADS 4. But what about the transitional zone, which is more difficult than the peripheral zone? The primary sequence in transitional zone is not diffusion weighted images. It's a T2 weighted images. And here comes the pyrethry again is a dilemma, because we can only see here ill-defined heterogeneous signal with obscured margin, which does not fall in 1 or 2 scoring, or doesn't fall in the 4 and 5 scoring system, because 4 is a lenticular hypointense lesion in T2 weighted images less than 1.5 centimeter, while pyreth 5 is a lenticular, larger lenticular hypointense lesion which is more than 1.5 centimeter. Is there, so what to do? We go in pyrethry T2 weighted images, we have a look on the diffusion weighted images. If there is no restriction, it's still pyrethry, and if pyrethry show a restriction diffusion weighted images, it will be upgraded to pyreths 4. So when to use contrast media? I mean multiparametric MRI. In clinical practice, some have viewed that dynamic contrast enhancement is a safety net or backup sequence, especially when diffusion weighted images is degraded by artifacts or inadequate sequel to noise ratio, as Professor Giganti said. So MRI, multiparametric or contrast injection with the multiparametric is indicated in previous negative MRI with persistent clinical suspicion, or when the diffusion weighted images show a lot of artifacts. I mean by this, gas from the rectum, or any prosthesis of the body of the patient, or even the protocol of the technique is not okay, or the low level of expertise. When to not use contrast media? By parametric, when the low risk early detection population with the high risk of clinical significant prostatic cancer, as Gattis et al. Stated, and in patient when we can recall the patient again if we need contrast injection. We did a small study design for 50 patients in our Asr Al-Aini School and the Cancer Institute to evaluate the diagnostic accuracy of biparametric versus multiparametric. And we included all the patients with proven cancer prostate and excluded any patient with higher level of lower level than 4 nanogram in PSA or received the treatment before. And we did the right protocol. We did a 2 T2 weighted image sequence, a very good 2 T2 weighted image signal sequence with a small field of view, and in both axial and the coronal images. And we did a high B value, actually low, intermediate, and high B value, more than 1400 seconds per millimeters. And we did a good ADC mapping as well as T1 weighted images to negate any hematoma or hemorrhage. And then we injected the patient intravenous contrast enhancement in less than 15 seconds or faster. And we, for the image interpretation, we took into 2 radiologists, expertise radiologists, and at first in consensus, they look at the T2 and dynamic images with blinded pathology and the blinded contrast enhanced images. And they score from 1 to 5 to biparametric MRI. And then the 2 radiologists again interpret with T2 weighted image diagram, and now they can have a look on the dynamic contrast enhancement, and they score 1 of 5 according to multiparametric MRI. And the results were the 43% with clinically significant cancer Gleason score was more than 7, and in 7 patients, 13.7% were with a Gleason score less than 7. Multiparametric and abbreviated MRI also has comparable results regarding localization of prostate lesion, and in the biparametric classification, pyreth's classification was in the abbreviated MRI shows some pyrethry about 5.9%, while in the multiparametric there is no pyrethry, more certain. And so our result was that there is a pyrethry 3 patient upgraded to pyreths 4, which is statistically insignificant. Some of the case presentation, this is a 63 years old male with prostate volume of 72, and this is a T2 weighted images, and we show here hypointense lesion seen in the T2 weighted images in the right lateral and posterolateral aspect of the prostate, and this is correspond to a very deep hypointense lesion in the ADC and high signal intensity in diffusion. And so we give the patient a pyreths 5, and then after contrast injection, it shows a contrast enhancement with rapid washout in the signal intensity curve. And also the patient shows in his diffusion weighted images a small internal iliac lymph node, and so abbreviated protocol provides same conclusion as multiparametric approach. In case 2, a 60 years old male with prostate volume of about 34 cc's shows suspected C2-weighted images here in the periphery of the peripheral zone, and this hypointense lesion still correspond to a very low hypointensity in the ADC and the high signal in the T2-weighted, in the diffusion-weighted images. And this is given as PIRADS 4 to 5, and when we inject the patient, it revealed a larger size of contrast enhancement of the lesion, more than the biparametric imaging, and it revealed a plateau signal intensity curve. And this patient proven to be Gleason score 4+4, 8. In this case, multiparametric approach showed larger size of lesion than the abbreviated or the biparametric protocol, yet this didn't affect the PIRADS scoring or clinical staging. And the last one is the case 3, in which it a suspected small hypointense lesion in the anterior fibromuscular stroma, and it was, when we looked at in the signal in the diffusion weighted images, shows some restriction at not really well seen in the ADC, and so PIRAD 3 was given according to biparametric MRI. But when we give the patient intravenous contrast, it shows a good enhancement, and so in this case, the proven in multiparametric approach surpass abbreviated protocol, proven prostatic carcinoma of score 7, 3+4. Our limitation was as a small sample size of the study, and we didn't actually separate the peripheral zone from that of the transitional zone to investigate the added value of dynamic contrast enhancement in each separately. And so, what I want to say at last, the newly proposed abbreviated MRI protocol can be used as a triage test in patients with high risk of prostate cancer, since it statistically did not have a significant underperformance compared to the standard multiparametric in detected clinically significant cancer protocol. That's a must condition that the protocol is good, that the diffusion weighted images are perfect, that the technician can do the protocol very well, and with a good expertise radiologist. Thank you very much. Thank you.